George Adams, interventional cardiologist, Raleigh, North Carolina. Thank you for joining us at Rex Hospital today. Today's session is going to be a tactical session on access in order to save limbs. So let's start off. Simplistically, I typically try to think of the anatomy at 3 levels. The first one is the inflow or the iliac system. The second is the superficial femoral artery and popliteal arteries. And then lastly, below the knee specifically, tibial and pedal anatomy. So let's start off with iliac occlusions. So commonly, we access the contralateral femoral artery, place a catheter at the level of the aorta and take pictures. It allows us to see exactly what happens. Now, when we see an iliac occlusion, if it's not a flush occlusion at the level of the common iliac, you may have the opportunity to come up and over. However, sometimes we lose support. And if that's the case, there's 2 other ways, in my opinion, that we would access to cross this. The first one is a brachial or radial approach, usually the left arm so we don't have to traverse the great vessels, and we save in length because we lose length if we come from the right arm. The nice thing about this is that it gives you a straight line into the iliacs to give you support. The second access point would be the common femoral artery on the side of the lesion, such that you come from a retrograde approach crossing the iliac occlusion. Now, if it was a flush occlusion, rather than having enough length such that you could come up and over, then we would be forced to either come from a brachial or a common femoral artery approach. The nice thing about having the contralateral femoral approach is that you can inject such that you could see exactly, especially in a flush occlusion, where you would place the stent if you were coming from the same side femoral approach. The second an anatomical distribution is the SFA and popliteal occlusions. Typically what I do is I come from a contralateral femoral approach and I'll try to cross from an antegrade fashion. If I can't, then that's when I would go for another access site. If there's not enough room for me to place an antegrade approach, and why would I use an antegrade approach? It would be for stability and support. To place it, to come from a contralateral femoral antegrade approach, you need enough room at the level of the superficial femoral artery. So you need at least a neck on that superficial femoral artery to place the sheath. Again, if it's a flush occlusion, much like the iliacs, which we discussed a minute ago, then we need to come from a retrograde approach. There's a couple retrograde approaches. The first would be a popliteal approach. And you can come from a medial supine approach where the patient is laying flat on his back, and you'd place the needle from the medial approach and stick the popliteal artery. Usually I do that under direct visualization from above. The other route is flipping the patient and sticking the popliteal artery directly from the back of the knee. To do this, you need to make sure you have a long sheath in place coming from the contralateral femoral approach, if that's the access site you would use to visualize from above, or you could use a brachial or radial approach such that you could visualize from above, such that you could cross and treat from below. The third section is the tibial and pedal chronic total occlusions. We're going to get posterior tibial access. We're going to discuss retrograde access, especially tibial access, and how to get it angiographically. Typically, if you have an ultrasonographer in your lab that is competent in actually guiding you in tibial access, I would strongly recommend it. It decreases dye and radiation. However, most of the people in the world don't have access to someone that is competent in tibial access using ultrasonography. So you need to be versed in the angiographic techniques to obtain this access. So for posterior tibial access, to access it angiographically, remember the posterior tibial artery is medial. So we want to bring the camera, since we're working on his left leg, we want to bring it in an RAO. This is set up in at about a 20 degrees RAO. Remember, when we take the needle, it is going to be parallel to the beam, okay, and perpendicular to the vessel. Parallel to the beam, perpendicular to the vessel. So the beams are coming down, needle's parallel, Vessel's running this direction, perpendicular to the vessel. It's so important. As you're watching it angiographically, so what we've done is we've taken a fluoro-subtracted still image of the shot, and we place it up there, and we're going to watch it real time as the needle goes through the vessel. Okay? So let's do this. And sometimes you can feel it pop, and usually I have someone watching as I do it.
Got it.
To see when I get blood flow. So we've got good blood flow, as you can see. It took a matter of maybe 5 seconds to access. Okay, so if you're comparing angiographic access to ultrasound access, it's just as quick. You just have to use these techniques. If you look at the hardest ones to access, typically the posterior tibial is the hardest, perineal is the next easiest, and anterior tibial is the easiest. The reason why is the anterior tibial is held in place and it's superficial. The perineal is held in place even though it's deep. You have great landmarks with it being behind the interosseous membrane. So you feel one pop, and then right behind that pop is the perineal. But the posterior tibial, even though it sometimes is a very large vessel, it tends to move. It's not held in place. So it tends to roll off your needle. All right, so we're set up for perineal access. So let me show you how to do this. The first thing we're going to do is take a fluoro-subtracted shot so we know exactly where we're going. And then we're going to access the leg. That's good. For the perineal, remember, we're going to splay our camera, LAO, since it's the left leg, so you splay the tibia and fibula. The perineal will run right in between it. Then we're going to take a micropuncture needle. We'll go through, we'll feel one pop as we're going in. Okay, that pop will be the interosseous membrane, and then the second pop will be the perineal artery that lays right behind it. So what we've got now is we've got the perineal access in place. Did you get this, Dave? Yeah. Perineal access in place. It was pretty straightforward. It took us less than 10 seconds to get it. Remember, the needle should be parallel to the beam, perpendicular to the vessel. You'll hit the interosseous membrane, which will be your first pop, and then right behind the interosseous membrane is the perineal. Again, this is a great technique, and everyone should become versed at it, especially from an angiographic approach. It's very difficult from an extravascular ultrasound approach to visualize the perineal. So again, angiographic visualization and understanding this technique is important.